Welcome to the SIBO Doctor Podcast with Dr. Nirala Jacoby, a US-trained naturopathic physician and medical director of the SIBO Doctor, an online education resource for practitioners. This podcast is intended for SIBO treating practitioners and aims to help educate how we may best serve our SIBO patients. Medical experts join us to discuss functional digestive disorders, clinical practice and research as it relates to SIBO and associated conditions. Head over to thesibodoctor.com where you can learn everything about SIBO from the basics to advanced treatments. You can also join in the conversation on the SIBO Doctor Practitioner Forum Facebook group. If you're a patient, please note this information is not intended to diagnose or treat medical conditions. Please ask your doctor before initiating any new treatments. We welcome you to head over to the SIBO Lifestyle Facebook group, where we post frequent tips and videos to help you on the road to gut health recovery. And now, over to Dr. Jacoby and the SIBO Doctor Podcast.
Welcome, SIBO practitioners, to another episode of the SIBO Doctor. Today with me, actually, we are filming this, so this is the first time that we are offering the video of this podcast as well. But with me today is Dr. Paul Anderson, a very, very well-known naturopathic doctor in the US. Dr. Anderson is a medical director of the Advanced Medical Therapies, a clinic focusing on the care of patients with cancer and chronic disease. Former positions include Professor of Pharmacology and Clinical Medicine at Bastyr University and Chief of IV Services for Bastyr Oncology Research Center. He is a graduate of NCNM and began instructing classes at naturopathic medical schools in the early 1990s. He continues to hold board review classes and CME courses for most of the US and Canadian ND programs and continues his educational outreach through www.consultdranderson.com. And I've certainly have seen Dr. Anderson speak on several occasions. We've crossed paths at the different SIBO symposiums and conferences, and really was, as always, very impressed by his incredible depth of knowledge, especially around the genomic issues. And I think, didn't you teach Ben Lynch? I think that he was your student. I mean, you talked about methylation pathways way before anyone else did.
Yeah, so technically speaking, Ben was a student of mine. We crossed over at Bastyr. As I was coming in, he was graduating. And I think he was on a couple of clinic shifts or something like that. And I was totally separate from that, though. I was talking about methyl cycle stuff and all of this a long time ago. And before I left Bastyr, I was full time there. I go and I do adjunct things now, but when I was still full time a few years back, before I left in what we called advanced naturopathic therapeutics, I started to teach about methyl cycle and SNPs proper. And what I told people was, I said, you're not hearing about this right now, but this is going to be the next thing that everyone's talking about, and so you should know what it is. And of course, that was a little ahead of the curve, so then everyone forgot. So, so right. I still get to talk about it all the time. It's great, yeah. But actually, Ben and I are actually friends. Yeah, we don't live that far apart, and we hang out sometimes.
That's great. I mean, it's amazing how it all evolved and how much more we know about it now. And still are discovering as genomics move ahead. But really the topic of this podcast, and the reason I'm so thrilled that you're on this podcast, is because I think you're truly one of the experts in biofilm, what there is to know about biofilm. And there's a lot of confusion about what actually works for biofilm. So I'd like to kind of deconstruct that a little, and then also because I just love, and I used one of your graphs famously for the histamine metabolism, and it makes so much sense to me now. And, as you know more, as you learn more about these different pathways, it all just starts to come together in a beautiful way. So I was hoping we could touch base on some of the aldehyde pathway, because I'm interested in that very much with histamine and candida. So moving into biofilm. Tell me everything there's to know about biofilm. No, I'm kidding. In your for those of you who are interested to learn more, I really do recommend that you purchase Dr. Anderson's course on consultdranderson.com. He's got a great biofilm course on that website. And he really talks about phase 1 and phase 2 biofilm. So before we move into that, maybe you want to kind of talk about how you got into biofilm research or figuring out how to actually treat biofilm.
So, yeah, I'll give you the very short version. I don't know how long, it was quite a while ago. I had a patient who, I don't even think she was really worried about biofilms as much as she was curious about them. And she thought she would periodically come in and tell me something I should, look into next. And so she came in one time, we were talking about her hormones or something like that. And she said, well, what do you know about biofilms? And I said, I listed what I knew at that time. Now, to be fair, I did a lot of chronic infection work even. So let's say this is 10 years ago or more. So this is not recently. So I knew a fair amount, but it was a really rudimentary amount about humans and biofilms. So there's a lot of information about biofilms in aquatic environments, the ocean and all that sort of stuff, and, maybe our mouth and our teeth. And then, everything else in chronic illness was really mysterious back then. And she just kind of piqued my curiosity and said, well, you should look into it some more now because, it seems to me, she was a very, very well educated patient, basically. She says, it seems to me this is maybe a huge factor in these people with infections and, that might help your practice. So I started to do more research and I started to be amazed at the amount of things that have been published about biofilms since I had last looked. And it wasn't, as opposed to say 20 years ago, it wasn't just about water environments for fish and other things. It was about people. And there was a lot of things about, okay, so they exist. What in the world do we do about them? So that kind of led into a good rabbit hole, but it was a bit of a rabbit hole. And it crossed over a bunch of other stuff that I did. It crossed over with heavy metals and crossed over with certain types of inflammatory products in the GI tract, all kinds of stuff that trigger biofilm. So that set about a year of me just digging into it because we had at the time, nowadays our clinic is about 80% advanced cancer and 20% chronic illness folks. In those days, it was about 60% chronic illness and 40% cancer. And so we had a lot of people with infections they just never cleared. And, probably before we knew, a ton about SIBO and the related problems there, we were probably seeing a lot of that too. So I was intently interested in anything that could help people past what were apparent breaks in their ability to heal that we just, we didn't know what they were. So that's kind of about the same time we also started looking at a lot of the genomic things because we could test them. We couldn't do that before. So the biofilm trip really started with curiosity and a lot of patients that needed help. And then I started to put just to string things together I was seeing in the research. And then I found some collaborators who were also doing research. And after I had been experimenting essentially with my patients, but experimenting with trying to break biofilms and all that and seeing, well, this worked better than this. And what was amazing was separately, everyone had kind of come to similar conclusions if you were kind of reading the research and all that. And then we all shared our experience with sick people. And then that led to kind of the next step. And it's certainly in the research, but this idea you mentioned earlier about, phase 1 versus 2, that's sort of my, there's one publication, you'll find that terminology in it. I wrote it, but that's my teacher's way of interpreting what all of the research said, which they don't really have names for. So the way I like to say it now is if there's a spectrum and on the left side, if you have normal which you all have normal biofilms, they're part of being a mammal, and they're also part of being in the ocean too, if you want to go that far. So there's like normal biofilms, no problem. They're just there. They do their thing. Then what we call phase 1 and phase 2 are just a progression of pathological biofilm. And that's where people get stuck, where they can't get rid of, say, an infection or a bunch of infections. The idea being the normal ones are just there. It's sort of like we have normal bacteria. We all have a little bit of candida. We all have a little bit of Pseudomonas or whatever. That's normal. It's when the stuff gets out of hand and overgrows that becomes a pathologic entity. Well, it's the same with biofilm. So what happens, and this is something I didn't realize people were looking at, but it turned out that a lot of North American government health agencies had already identified 10 years ago biofilms as one of the biggest problems in microbial resistance to treatment, which is a huge problem all over the world. And so then when I started looking at those papers, which were sort of indexed differently than biofilm, but they talked about biofilms, this whole progression of normal to sort of a weaker and a stronger biofilm came up. So that's where the concept came in. What turned out to be is then what you do about them is different, because the more complex it is, the more bugs live inside of it, the deeper it gets, the more protection the bugs have and all of that. So if you have the normal ones, you sort of leave them alone, like normal flora, and you eat the right food and you know, all that stuff. If you have the lower grade or phase 1, you have a lot of ways in to weaken them. But when your patients get really sick, what happens is the lighter ones, if you want to call it that, or phase 1, they collect more bugs into them. It's almost like they're trying to hide. They make a bigger, better biofilm, and then they act as a community to make you sick. And the other thing that we found, and this is just a teaser probably for the end of our discussion, but is opposed to what we were thinking originally, most of these actually, the worst ones are in your gut. So when you think about it, like whether it's SIBO or SIFO or any other gut problem, the longer it's been there, the more of this is going on. So that was sort of a revelation when that all happened. And a little bit later, we probably talk about how we figured that out. But yeah, so that's sort of the Cliff Note version of how I got into it. And it was really because people were sick and weren't getting better.
Yeah, and actually that was one of my questions, is how do we even assess for biofilm? Because there isn't, like, you'd have to actually do a biopsy of it. It's not like, if it's hidden, how do you even know? And I think there's sort of like this convention that we now think that any kind of chronic infection will have some level of biofilm, and chronic illness will have some level of biofilm. And that's where, me as a SIBO practitioner and functional digestive disorder practitioner, I see a lot of people that have had chronic illness, especially digestive disorders. And I get sort of mixed results with biofilm treatment. And I can't say that across the board I see amazing results every time I incorporate a biofilm treatment. So I was actually curious how you figured out, what works. And how to assess for biofilm, if there is such a thing.
Yeah. I wish beyond biopsies and things that there was a better across the board measurement. There are things being worked on, but the state of the art right now is either empirically looking at how sick and how they respond to things, and we can talk about that next, but there's one or two labs in the US that do biofilm residue measurements from blood samples. And then there's research labs that will actually go in and biopsy blood vessel walls and other things, and they can see them very, like in real time. Those tests they're interesting and they're good for research, but they really aren't great for most patient care, because like a peripheral biofilm. So the logic is, well, if I find traces of biofilm residue in your blood, it starts in the gut, so for sure it's there, right? Well, we've done a lot of those tests on people, and the sickest people, they always have it, right? The problem is you don't know from that how the gut has been affected and whether it was the kind of thing where a little gut stuff happened and then it just went right to the systemic circulation, or it's been there so long, like the gut has this giant problem, and then it went systemic. Because the other part about biofilms beyond the infectious world, well, related, is in cardiovascular disease and other problems that go on there. So that's more what these tests are looking at. So not that we totally quit doing those tests, but we kind of looked at it as it's $300 or $400 to do this test. If you had cardiovascular disease, I would probably do it. If you're having gut problems or chronic infection problems, we can probably assume how that test is going to come out. But then the next step is when you treat them, you essentially have to empirically look at if I do a phase 1, a lower level treatment and nothing happens, we kind of kick it up a notch and go to something stronger. Essentially what I tell people now is if you've done that and you've kicked it up a notch and you're having no change in their immune reactions or anything really, after about really 3 or 4 weeks, I've seen it take up to 12 weeks, like in PANs and pandas and stuff. But 3 or 4 weeks, if you've had no immune response and you're doing a lot of biofilm breakers, that's probably not their problem, or it's a little tiny problem. So we almost now do kind of what we did before we knew they were there, which is we treat them and we get this response, and it's like, oh, well, there's something here. We need to be very aggressive. While you can do some testing, it's sort of like, if you think back, like 20 years ago, most digestive system testing that we would do for pathogens was so rudimentary that you could almost guess that they had the problem without doing the testing. Mm-hmm. It's almost that way with the more advanced biofilms, because you get such a remarkable immune response when they really have it. And that's the part that I try to make the point to people, if they're the practitioner, you have to warn the patient and say, look, you nothing may happen or a lot may happen. And if a lot happens, here's what it feels like. And that doesn't mean it's bad. It means we have to then intervene because that's a problem. So when you start breaking any biofilm, but especially the big ones that have lots and lots of organisms, think of it this way. Your immune system has been unaware of a lot of this stuff going on, even though it's right there in your gut. Now you open it up and your immune system says, oh no, and it starts to react. Well, what happens? You get all these cytokines and chemistry flooding in your system. And we've had people, depending on what their original symptoms are like, they get all these things. They can get mentally affected. They get fevers. They get, achy all over, whatever. That's, it's sort of like the classic naturopathic thing of that's a good sign, right? It's a healing crisis. Well, it's a crisis at that point. So what it means is you've really poked the bee's nest. There is a problem there. So we know there's biofilm issues. But then what you have to do is say, okay, well, why does the body respond so, magnificently to this? And the biggest problems, which in your chronically ill people, if that bee's nest is the one that gets poked, is their adrenal reserve is usually so low that they don't have the ability to produce some cortisol to level the immune response. So they just get this wicked immune response. So what we normally have people do is we tell them, look, as soon as this happens, let us know. And it'll be something like, whatever your worst symptoms are, joint pain, headaches, don't sleep, whatever their thing is. And we tell them, don't worry about it, but let us know the moment it happens. If we already have them on adrenal support, we will. I've seen it take 5 to 10 times as much adrenal support as they're already on for like a week just to calm things down. We've had a few people where we had to give them like a biologic dose of steroid or something in real bad cases. But the bottom line is it's good in that you now know that's a piece of the problem. It's bad in that the immune system that's been kind of not caring about anything now cares a lot about all these bugs. So that's kind of nowadays, as opposed to spending the $300 or $400 on testing, we just say, let's do a treatment trial for 4 to 6 weeks. If you have these responses, and I always ask them, what's your worst flare up like? And if they say, oh, it's joint pain, or it's I don't sleep, or it's headaches, or I say, well, watch for that first, because it's usually almost always that. And then this is what we're going to do. So there's 2 kind of prongs to that. One is the adrenal cortical support, and the other is you want some broad-based anti-infective to just kind of, because you open it up, you get an immune response against all these bugs. The bugs are going to fight back. So what we do is aromatic herbs I really like the best, because they will kill or knock down almost anything, whether it's fungus or bacteria or protozoa.
Like oregano or something.
Yeah, like Mexican oregano is a really good one. Olive leaf. Sometimes some of the combos that have like thyme and rosemary. All those guys. As opposed to, if we don't really know what's there, you could give somebody, say, a drug of like an antifungal or an antibiotic or an antiparasite, but you're really guessing. You don't actually know who's in there. Mm-hmm. Whereas an aromatic herb, it doesn't matter. They're all going to kind of go there. So they usually get like an increase in adrenal support, an increase in aromatic herbs just for about a week to put the lid on. And then we sort of move forward and say, okay, I normally, if that happens, I'll rotate the biofilm support, because then the bugs are confused still. And then we kind of go after 2 things. One is empirically treating what probably is there. The next thing is, if they have that reaction 1 to 2 weeks later, usually if you do a stool test on them, they'll have completely different findings than they did before. And I have a couple of clinicians tracking this for me in people who respond. As you said, not everyone responds. If they don't respond, by the way, we just stop doing it. It's like, why do it, right? But if they do respond, often what some of my friends in Portland will do, for example, in Seattle, is they'll retest their stool 2 weeks in, and they've sent me the reports, and it's like stuff that was never on the initial stuff now is coming out. Well, they didn't just get exposed to it. It's now available. So that's kind of, it's an empiric treatment, and you watch for that. So the difference is the earlier ones, the pathogenic, like phase 1 or whatever, they respond to all sorts of stuff. So high dose enzymes, like most of us learned about,
like serpentase and NAC, that kind of stuff. So
all the big like serpentase. That's a good example. And some of the other big dose enzymes. Also, like thiols, like NAC or ALA, will trigger this response if it's not too ingrained. Almost all those things. So also phenolic compounds, which are mostly anti-infective or have some phenolic component. So if you've given somebody those things and they react, that's good, because it's not as advanced, but also there's a lot going on there.
That makes sense. Okay, because I was a bit confused initially about like how do you know if somebody has a phase 1 or phase 2? So that makes a lot more sense that you can start out with the lighter stuff, and if you're always looking for a response. That's sort of what I'm gleaning from what you're saying. You're always looking for a response. If you're not getting a response, you have to move up the sort of ladder to stronger components. And you formulated several different formulas. One for priority 1 just recently, and called phase 2 advanced or something, right? Which is more of an over-the-counter, like not over-the-counter, but not prescription. Well, which is over-the-counter. And you actually graciously let me use that formula, and I've compounded it here at the pharmacy. And I'm just wondering, because I'm not seeing a whole lot of those really strong responses that you talk about. I'm just wondering if I should go back to the compounding pharmacist and ensure that those products, like the ingredients, are exactly what you've told me to do.
So here's what we've noticed now that there's 2 main formulas that for the deeper, like the phase 2 ones that I worked on. Neither are patented; they're all just based on the available science and all that. But in North America, like the one you mentioned, that's more of a supplement, is a weaker bound, what they call bismuth thiol complex. It's got some black cumin, which is also a good biofilm agent, but the bismuth thiol is very weak. We also, because of our pharmacy rules, So that can be sold over the counter as a supplement. Because of our pharmacy rules in North America, the stronger one has to be made as a prescription-only item. And the strength is in how tight the bismuth and the thiol bind, okay? And so the pharmacy version that we have that's not a supplement you would need a prescription for has two components, one of which is in North America illegal to sell as a supplement. So, and the reason, not that it's illegal, but the reason it works better and we get bigger responses is it actually makes that new molecule more reliably. So the one that we use as a supplement, it's still a BT, a bisthiol. It's just weak bound. And so in our experience in our clinic and other people, if we really think someone's super sick and we want to push, a big response, we'll do the prescription only one.
Okay. That's the Biosolve PA?
Yeah. So that's actually the chelator DMPS and bismuth subnitrite bound together as a new molecule. And then we put ALA with it to increase the thiol binding.
Yeah.
That one, you're more likely to get these real wild, sick people having big wild reactions. So the components that make the strength, see what you want to think of it as, this actually sort of drives itself into this hive, this place that all the bugs hide. And the tighter that molecule is stuck together, the better of a wedge it is. If it likes to fall apart, it still works, but it's sort of weaker, sort of like in the middle. So the pharmacy only one in North America has a dithiol DMPS, which is a chelator, and then bismuth subnitrate, and they actually stick together and they don't want to come apart. So they get down there and most of it doesn't ever fall apart, which means it's a better wedge. So it's sort of like the over-the-counter one is, here, and then the prescription one is like over here. The other thing is that there's big pharmaceutical companies, because this is such a big problem in hospitals, that they're working on this concept only like taking it to a whole next level for all sorts of very, very bad infections. And what they're doing that will make it patentable and all that is it's not only the two binding strong, but they actually are getting them in really tiny molecule size.
Thank you for listening to the SIBO Doctor Podcast. We hope you found the information in this episode useful in the treatment of your SIBO patients. Thanks to our sponsors, SIBOtest.com, a breath testing service with easy online ordering, and Quintron, maker of outstanding breath testing equipment. Tune in again for another episode of the SIBO Doctor Podcast. Thanks again for listening.